Dereta, dereta, dereta. Stop, stop, stop. Okay, okay. Hop, 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 hop. No le mueva. Ah, las paragus.
Hey guys, what's up? This is Stephanie and welcome back to my channel. So in the video today, I'm going to be making a video talking about medications in psychiatry. So psychiatric medications like your antipsychotics and your antidepressants, benzodiazepines, etc. The purpose for this video is to help you hopefully study for your end of rotation exam for PA school, specifically for your psychiatry rotation. If you haven't checked out my other video, which I'm going to link below, I made another video in regards to your psychiatry rotation. So I discuss a lot of psychiatric illnesses like schizophrenia, major depressive disorder, etc. So I also talked in that video about high yield things, basically what I saw when I was taking practice questions, what I remember when I was getting tested for the exam, and this high yield thing. So hopefully that video is helpful for you guys, and you guys can also use it in conjunction with this video. So let's start. And hopefully this video is also helpful for you, those of you who are preparing for your clinical year. I know psychiatry is actually one of the easier ones, in my opinion, for the end of rotation exams. So make sure that if you can, to try to get a good grade in that EOR. Alright guys, so let's start with the medications. So I'm going to start with SSRIs. So what do the SSRIs stand for? It's going to be the selective serotonin reuptake inhibitors. I also have my notes in front of me, so if you see me looking down a lot, it's because I'm looking at my notes. So I'll try to look up as much as I can to the screen. Also, if I have any mistakes, feel free to correct me down in the comments below, okay? So SSRIs are commonly used for a lot of psychiatric illnesses. For example, major depressive disorder, even some of the eating disorders like bulimia. And interestingly, like I had stated in my previous video, in eating disorders, anorexia, the first line treatment is, of course, you want to get the patient to start eating. So you want to feed them. You also want to do some family therapy, some cognitive behavioral therapy. Versus bulimia nervosa, first line is usually like an SSRI. So examples would be fluoxetine, citalopram, escitalopram, fluvoxamine, paroxetine, also sertraline. But for bulimia, the most commonly one I saw that was prescribed was fluoxetine. And fluoxetine is one of the most commonly ones I saw also on questions when I was taking the exams. So make sure that you are very familiar with this medication class. It can be used, like I said, for a lot of things: major depressive disorder, OCD, panic disorder, social anxiety disorder, PTSD, and generalized anxiety disorder also. Also make sure that you're very familiar with not only the brand name, okay? So citalopram, also known as Celexa, escitalopram, known as Lexapro, fluoxetine, also known as Prozac. We have fluvoxamine as Luvox, paroxetine as Paxil, and sertraline, also known as Zoloft. And just make sure that you are familiar with the other names, because in clinic this is going to be very important. In clinic, my doctor always used, for example, Lexapro, and I had to go and print out my notes, and I keep flipping back and forth to make sure what is Lexapro. I just know it as escitalopram. What's Prozac? I just know it as fluoxetine. So make sure you're familiar with both of the names. But for the exam, I usually just got fluoxetine, fluvoxamine, paroxetine. But just make sure that you know that these are SSRIs, so selective serotonin reuptake inhibitors, okay? And in regards to the pregnancy risk category, what you have to know is that paroxetine is class D, okay? That's usually the only one that is class D. The rest of them are class C. So paroxetine, you want to make sure that you don't prescribe that for children. And in regards to side effects, they all have very similar side effects, which were your sexual side effects: nausea, diarrhea, insomnia. But the key is going to be sexual side effects. I got that so many times on questions, so make sure that you know that. You would get a patient that just was placed on an SSRI and they're having sexual dysfunction. Usually it's a male, and you had to go and ensure that you knew that the medication that was causing this was an SSRI. So you had to look at your answer choices, and it would be something like escitalopram, fluoxetine, paroxetine. Just make sure that you pick out the SSRI from there. So sexual side effects is actually one of the huge side effects. Also weight gain. So these patients can also gain a lot of weight on these medications. And specifically for citalopram, you want to watch out for serotonin syndrome. Remember we had discussed that earlier. And Basically, what is serotonin syndrome? It's when the patient starts having increased blood pressure, heart rate, fever, diaphoresis, right? Everything's increased. Hyperreflexia, clonus, agitation, increased liver function tests, metabolic acidosis, and usually with serotonin syndrome, how do you treat it? So you treat it with cyproheptadine, okay? And another question that I had was, which one of these SSRIs have the longest half-life? It's going to be fluoxetine. So make sure that you know that fluoxetine has the longest half-life. And which one of these SSRIs are approved for OCD? Fluvoxamine, okay? Also known as Luvox. And also paroxetine is known for having sedative effects. So just make sure that you know that paroxetine is very sedative. And which one of the SSRIs has the fewest drug-to-drug interactions? It's going to be sertraline. Okay, so just make sure that you know these. So once again, which one of the SSRIs has the longest half-life? It's going to be fluoxetine. And which one of the SSRIs has the fewest drug-to-drug interactions? It's going to be sertraline. What is a major side effect for these drugs? It's going to be sexual side effects, and they can also cause weight gain, but sexual side effects for sure. Interestingly, as we had discussed in the previous video also, SSRIs are used for sexual arousal disorders, which makes sense, right, because of their side effect. Okay, so we're going to move on to the SNRIs, selective norepinephrine reuptake inhibitors. So for these, the ones that you really have to know are duloxetine, also known as Cymbalta, and venlafaxine, also known as Effexor. My doctor prescribed venlafaxine left and right. He prescribed it so much. This is actually a pretty safe drug. And when some of the patients would ask me if I knew anything about the drug, I would tell them, you know what, this is actually one of the very, very safe drugs for depression. So venlafaxine and then duloxetine. So these are class C. Once again, what is the side effect with these? Similar to SSRIs, they do cause sexual dysfunction, but it's less than SSRIs. So if in a question stem you have a patient that has sexual dysfunction and they give you an SNRI and an SSRI, I would go with the SSRI because SNRIs have a less effect of sexual dysfunction in comparison to the SSRIs which have a higher effect of sexual dysfunction. Okay. Another thing that you need to know is that for duloxetine, you can also use this for neuropathic pain and fibromyalgia. So if you have a patient that has fibromyalgia, usually a patient that has fibromyalgia also has depression associated with it, then you can prescribe him something like duloxetine. Okay. And then for venlafaxine, they usually tend to have withdrawal symptoms also if the medication is discontinued quickly. Also, some other side effects with these medications is that for venlafaxine you can have hypertension, headache, dizziness, and then with duloxetine you can have hepatotoxicity. But of course, just make sure that you also are aware that these medications also do cause sexual dysfunction, okay? So now we're going to go with norepinephrine and dopamine reuptake inhibitors. So this is your bupropion, also known as Wellbutrin. And this medication is used for tobacco or meth cessation, as we had discussed in the previous videos. And it's actually a very safe drug. And it's also used for ADHD, but you have to make sure that with this drug, so bupropion, this is something I got tested so many times, is that you do not want to use this medication in patients that are anorexic or bulimics, okay? Because it decreases their seizure threshold. Or even a patient that has constant seizures or they're epileptic, you want to make sure that you do not use bupropion. So make sure that you know that because I had so many questions on this. So bupropion, you do not use it in anorexics or bulimics, and also patients that have epilepsy because it has a decreases seizure threshold. Okay. Interestingly, this medication has no sexual side effects, but you can get side effects like seizure, anxiety, agitation, and psychosis. So next medication is going to be Trazadone. This one in class I learned it as Trazabone, because this medication has the side effect of priapism, and I actually saw this in clinic a lot. Patients did not like being prescribed Trazadone because they had erections and they didn't like that, especially, of course, the males. So make sure that you know this about this medication is that it causes priapism, and this is Trazadone, Trazabone. That's how I memorized it. and this is a serotonin 2 antagonist modulator. Other side effects that it causes is sedation, nausea, orthostasis, arrhythmias also, but of course the big one, like I said, is priapism. So what is trazodone used for? Trazodone is usually used for sleep. That's what it's indicated. Interestingly though, its side effect is sedation, and that's what it's used for. So it's used for its side effect, which causes sedation, and that's why it's used for patients to sleep. Okay? So patients that are complaining of insomnia, you can consider giving them something like trazodone. But my doctor in clinic didn't prescribe it as much because patients don't like it because it causes priapism, especially males. So now we're going to go on to mirtazapine. This is a noradrenergic serotonergic antidepressant. Okay. This one has side effects of sedation, and it also increases appetite. And this medication, mirtazapine, is usually used for patients that are like very, very skinny. Especially like elderly. You can give it to them and it increases their appetite, it helps them gain weight. So you can consider that in a patient that is complaining of depression and they're also having trouble eating and they're really skinny, you want to help them gain weight, you can give them something like mirtazapine. And some of the side effects that you need to know with this medication is that at low dose it has an antihistaminic effect. So at low doses, it will cause sedation, increased appetite, and at high doses, it has an increased anti-alpha-2 effect. So it causes increased of norepinephrine, and it improves mood by doing this. Okay. So now we're going to go on to the tricyclic antidepressants, also known as your TCAs. So these can be used for refractory ADHD, but of course they're not first line because as we learned, first line for ADHD is usually stimulants. If not, then you can give them like a non-stimulant like atomoxetine. But for TCAs, amitriptyline, you have clomipramine, doxepine, imipramine, and amoxapine. And if you notice the pattern here, they tend to end in -ine, so that's how I memorize them. Amitriptyline, right? Clomipramine, doxepine, imipramine, and amoxapine. So amitriptyline can also be used for pain, so neuropathic pain. So if you have a patient that they're depressed and they have pain, you can consider something like amitriptyline, okay? And clomipramine can also be used for OCD, and I memorized clomipramine as C and OCD and C in clomipramine. So that's how I memorized it. That OCD, you can use clomipramine since it has a C. So if you have a question that asks you which one of these tricyclic antidepressants is indicated in OCD, then you can use something like clomipramine, which is a TCA. Imipramine, you can use that for panic disorders, so it's indicated for your panic disorder. And something you want to know about these medications is that they are class D, so you not want to use these medications in pregnancy because they can cause limb malformation, perinatal withdrawal. And side effects of medications, once again, sexual dysfunction. It seems like sexual dysfunction is very common in the antidepressants. But clomipramine is usually prescribed for premature ejaculation for the same reason. They also have anticholinergic effects. Make sure that you're very familiar with this. I had a lot of questions on this. So if a patient is complaining of a dry mouth, then make sure that you look in the question and see if there's any tricyclic antidepressants that can be the culprit of causing this. They can also have mania, increased weight, and these are very common to be used in overdose. And you want to be careful with these because they can cause a lethal overdose. They can cause a coma, convulsion. They're well known for cardiotoxicity also. And they have a lot of drug-to-drug interactions. So you want to make sure that you get a baseline and routine EKGs to monitor their QTC. So once again, tricyclic antidepressants, one thing that you have to know is that they also cause sexual dysfunction. They have anticholinergic effects. They can increase your weight. And specifically, they have a lot of bad side effects, right? They can cause coma, convulsion, cardiotoxicity is one of the big ones. So you want to make sure that you get a baseline and routine EKG to monitor their QTC and make sure that it's not prolongating, okay? So now we're going to go on to the monoamine oxidase inhibitors. These are your phenelzine and your selegiline. Of course, you have a lot more, but these are the common ones that you're going to be seeing in your exam. So these medications also are pretty bad. They have a lot of side effects. They actually used to be used as first line in the past before the SSRIs came out for depression, but then they started seeing how many side effects that they have because they're really bad. They have a lot of side effects. These medications, you want to make sure that you do not use them with any SSRIs, SNRIs. Okay, it's really, really important that you know that, and any of the NDRAs. So of course, you do not want to use this with bupropion. So it's really important that you do not use this with any other type of antidepressants. Some of the side effects that they have headache, hypertension, insomnia, but the big one that you have to know, and it's really important that you know this, is that they cause tyramine-induced hypertensive crisis. So these patients that are taking these monoamine oxidase inhibitors like selegiline and phenelzine, you have to be careful with what they eat. They can't eat anything that has tyramine, for example, wine, meat, red wine, meat, cheeses, and they have to have a very specific diet. So that's why we started moving away from these medications. And you also want to make sure like you don't take any SSRIs or SNRIs because they can have a really bad synergistic effect on the patient. And these are usually used for refractory depression or anxiety. So if SSRIs and then you've tried SNRIs and TCAs, these aren't working, then you can consider this, but we usually try to stay away from them because of the side effect. And usually, if you do want to start an MAOI, then you have to make sure that you do stop the SSRI 2 weeks before you start your MAOI to ensure that the patient has gotten rid of all of those SSRIs or the medication from their body. So once again, MAOIs, they have a lot of side effects. Specifically, the huge one that you're going to see is that they cause tyramine-induced hypertensive crisis. So the patient has to be on a specific diet. They have to avoid wine, cheeses, and meats, okay? And you want to make sure that you also do not give these medications with any other antidepressants like SSRIs or SNRIs because they can have a lot of side effects. Okay, guys, so the next one's going to be, we're going to go into your antipsychotics. So we have the first and second generation of antipsychotics. So second generations are the new ones, the newer medications. Another way you might see these medications are your typical, which is your first generation, and you have your atypical, your second generation. So the second generation are known as the cleaner drugs. They're newer, they have less side effects, and they have a better mode of action of working in the brain. Less extrapyramidal side effects also, versus your first generation of drugs. Those are more of the dirtier drugs. They have a higher extrapyramidal side effects. They have a lot more worse side effects than the second generation drugs and the newer ones. So this is why we use the second generation drugs more than the first generation drugs. So for your typical first generation drugs is that, like I described, they have a high potency and they have increased risks for extrapyramidal side effects. I'll discuss in a few minutes what extrapyramidal side effects are. So we have high potency, medium potency, and low potency in regards to your first generation typical antipsychotics. And what is potency? That's basically the level of affinity for dopamine receptor blockade. So as we had discussed in the previous video for your psychiatric illnesses, and most of these antipsychotics, they tend to be used for schizophrenia, right? You can use them also for bipolar disease. So what is the pathophysiology of schizophrenia? So in schizophrenia, patients have an increased amount of dopamine. And what do these drugs do? They're anti-dopaminergic, so they decrease the amount of dopamine. And first generations tend to be really good at doing that, and they can decrease it so much that the patient will have these extrapyramidal side effects, okay? And so high potency, we have fluphenazine, also known as proloxine. We have haloperidol, also known as Haldol. You guys are probably very familiar with these, especially the ones that work in the ER. Usually a patient that comes in and they're psychotic or they're being aggressive, they'll just give them a shot of Haldol and it will knock them out. So just make sure Haldol, haloperidol, first generation, high potency. I had a lot of questions on this, okay? And then you have your medium potency. So you have your perfenazine and your thiatoxine. Okay. And then you have your low potency, you have your chlorpromazine and thorazine, also known as thorazine. And these are category C. Some of the side effects for these medications that I'm going to discuss now is dystonia. So make sure that you're very familiar with side effects. Usually you'll get a question stem where it will describe a patient, and the patient will be on an antipsychotic and they're behaving a certain way. They're either very hyperactive or they're moving their lips a lot. So you have to make sure what side effect that is, and also make sure that always a culprit for that is going to be your first generation, right? Rather than your second generation, because your first generation drugs are a lot dirtier than your second generation drugs. Whenever I read those questions, I'm always like, shame, shame on the provider or doctor who prescribed this patient a first generation antipsychotic when they have these newer second generation antipsychotic medications. So side effects, dystonia. This is usually the first one that will appear. It's acute, so it's going to appear within hours. So also make sure that you are familiar with the timelines of when the side effect is going to appear. Okay? So it's acute within hours. They have this sustained painful muscle contraction of the neck, tongue, or eyes. And treatment for this is usually benzodiazepine, cogentin, or diphenhydramine Benadryl. So what is cogentin or benzodiazepine? This is a dopamine agonist. So like I said, what do typical antipsychotics do? They deplete the patient's dopamine in their brain. So what is going to cogentin or benzodiazepine do? It's going to increase the amount of dopamine you have. Okay? Hopefully get it to that normal level that the patient had it prior to taking their antipsychotics. So this is why you give something like benzodiazepine. So treatment, benzodiazepine or diphenhydramine. Next one, akathisia. This happens weeks later. So you first get dystonia, which is acute, and then akathisia, which happens weeks later. So if in the question stem, the patient says that they've been on this medication for 3 weeks, and they start having symptoms of anxiety, they're fidgety, they're restless. The thing that I saw a lot in clinic was that the patient would just bounce their legs a lot, and they couldn't sit in the chair when they were talking to my doctor. And that was it. That was akathisia. They were on antipsychotics. So this usually happens weeks, and treatment for this is propranolol. You can also give them like a benzo like Valium. That makes sense, right? Because the patient's very hyperactive. You want to chill them out, give them a beta blocker or propranolol. Next one's going to be Parkinsonism symptoms. This is usually months later. Okay? So symptoms will be similar to Parkinson's disease. So they'll have that pill rolling tremor. They'll have that cogwheel rigidity, bradykinesia. Their movements are very, very slow. You know, they have that face mask, literally like where their face is just not moving, or this emotionless face. And treatment for this is going to be amantadine. And then you have tardive dyskinesia. This is years. I actually saw this in clinic. And for these patients, they tend to have a writhing movement of the mouth and tongue like they're chewing gum. So the patient that I had, she was a schizophrenic. She had been taking antipsychotics for years, and she was just moving her lips, and she just couldn't stop it. She literally kept going like this and this and this, and it was really sad to see. So usually it's a repetitive movement, usually in the mouth. That's how they'll usually describe it also. And if you notice, this is years after taking the medication. So with this, you want to usually lower the dose, which is what my doctor did. And he was actually trying to treat also the movement because it was so distressing for the patient. You can also discontinue the antipsychotic. You can give him something like tetrabenazine or valbenazine. And for the antipsychotics, what you have to know is that they all decrease also seizure thresholds. So you want to watch out for this also, and then also watch out for orthostatic hypotension. So what are some hints? Okay, so for these typical first generation antipsychotics, you want to watch out for neuromalignant syndrome, right? So for the SSRIs and the antidepressants, it was serotonin syndrome, right? Now for these medications, the antipsychotics, specifically the first generation, you want to watch for neuromalignant syndrome. So what is this? This is fever, tachycardia, hypertension, lead pipe rigidity, leukocytosis. So what is the cause of neuromalignant syndrome? It's basically your depletion of dopamine receptors. So like I said, what do these typical antipsychotics do? They're dopamine antagonists, and that's what they usually target only, is your dopamine receptors. So they're depleting this amount in the brain of dopamine. And if they deplete it so much, then you can get something like neuromalignant syndrome. And I had a patient that actually had this. She was actually on a second generation antipsychotic, but she still had these symptoms, and she was following up, and her parents were so worried and they were so scared. She was schizophrenic, but the parents still wanted her to be treated for her schizophrenia because it was so bad, but they were scared of the drugs and the drug side effects. So I remember talking on the phone with them and explaining to them the mode of action of antipsychotics, how they work in the brain, and the reason why the patient was having these symptoms, and the reason why my doctor had prescribed something like bromocriptine to them, which is a dopamine agonist. Okay. And treatment for this is going to be dantrolene, treats muscle rigidity, bromocriptine, it's a dopamine agonist, and you can also cool them. So like I said, first generation antipsychotics, they have a high extrapyramidal side effect potential. So you want to be really careful with these drugs and make sure that you know this for this. And another question that I had is that, interestingly, which one of these first generation antipsychotics can you use for intractable hiccups? So a patient that's hiccuping a lot. And the answer is Thorazine. Yes, so Thorazine you can actually use for intractable hiccups. I had a question on my Rosh for that, and I was so mad I almost threw my iPad. But yes, Thorazine, you can use it for intractable hiccups. And for thyroidazine, you want to watch out for retinitis. So make sure that you know that retinitis and thyroidazine, which is also a low potency first generation antipsychotic. Okay guys, so next video is going to be your atypical second generation antipsychotics. So these are a lot cleaner than your first generation because they not only target your dopamine receptors, but they also target your serotonin. So they have dual. So they target both dopamine and serotonin versus first generation, it's only your dopamine. So this is why these drugs are a lot better than your first generation drugs. So with these drugs, you want to make sure that they, at baseline, you want to make sure that you monitor their weight, okay? You monitor their waist circumference or blood pressure, their fasting glucose, their A1C levels, their lipid profile, because these medications can cause weight gain. And this is one thing that my doctor did for every patient that we saw, is that he got a weight every time they came in. So every time we saw them, we got a weight from them. And since I was working with him through the whole COVID-19, we did a lot of video chat with the patients and phone calls also, because of course they couldn't come into clinic. And what we did is that we also asked them every time that we talked to them on the phone, what was their weight, to track if they had gained any weight or lost weight, because we want to make sure that we're monitoring that, especially with psychiatric medications, because you have medications like your SSRIs that can cause weight gain, your antipsychotics that can cause weight gain, and then you have medications for ADHD, stimulants that can actually decrease your appetite and cause decreased weight. So this is why it's really important to make sure that you're monitoring their weight. So what are some of the examples for your atypical second generation antipsychotics? So the big one you're going to see is going to be clozapine, also known as Clozaril. This medication is contraindicated in myocarditis, so make sure that you know that. You also have quetiapine or quetiapine, also known as Seroquel. You have Lorazepam, Latuda, Risperidone or Risperdal, Paliperidone, Invega. My doctor prescribed this so much. Olanzapine, Zyprexa. And for these medications, the only one that is class B is clozapine. And with clozapine, you have to make sure that you know that its side effect is agranulocytosis. So this is why you have to make sure that you're looking at their labs and you're doing labs on them constantly, because it can deplete their granulocytes so much that they can get secondary infections or be more prone to getting bacterial infection or viral infection, etc. So you have to make sure that you're monitoring that. Also, so once again, agranulocytosis, big for clozapine or Clozaril. You also want to watch out for weight gain, metabolic syndrome, seizures, and myocarditis for clozapine. So these medications, clozapine decreases suicidal ideation, same like lithium. But like I said, you need constant follow-up, specifically for their white blood cell. Weekly, you want to check their ANC level, make sure that it is greater than 2,000. So your ANC is your absolute neutrophilic count. So you want to make sure that you're always checking that. And my doctor did that a lot, specifically for patients that were on clozapine. Because like I said, it causes agranulocytosis, and if the patient's neutrophils or white blood cells are depleted, then they're not going to be able to fight any infections, right? Bacterial infections, viral infections, and they're more prone to getting sick from these infections. So that's why you have to make sure that you check their ANC. If you can, for 6 months, and then after that, twice every 2 weeks for 6 months. So this is something you have to know. Once again, agranulocytosis, clozapine, you want to make sure you're checking their ANC. It's greater than 2,000. If their ANC is 1,000 to 1,500, then you want to increase their monitoring, keep dosage. But if their ANC is 500 to 1,000, which is really low, you want to stop the dosage and monitor them and resume the medication once their ANC has increased again to 1,000. And you want to discontinue if their ANC is less than 500. So you want to make sure that you are paying attention to their ANC. So this question, how I saw it, is that there's a patient that's on clozapine, and then their ANC is 800, and then it asks you what's the next best step. So make sure that you know that if it's less than 500, you want to stop it, and then you can continue it again once it's greater than 1,000. And you want to make sure that you are monitoring these patients' ANC for 6 months. Okay. Okay. So for Seroquel, we have to know it's sedative, so you can actually use this also for sleep. My doctor used this a lot for sleep, so quetiapine, also known as Seroquel, he gave that a lot since a lot of patients didn't like Trazadone since it causes priapism. But there's a lot of debate on Seroquel and how safe it is, and I know certain doctors don't like it, but my psychiatrist prescribed it a lot. So just make sure that the side effects, it's sedative. It can also be used for bipolar depression for Seroquel. And it has very little extrapyramidal side effects, right? Because it's a second generation antipsychotic. And another thing that you have to know that I have started on here is that quetiapine and clozapine are the least dopamine antagonists, so it's very safe to give to elderly. So we want to be really careful with elderly, right? Giving them these medications because they're a lot frailer, and since some of these medications cause really bad side effects, it's easier for them to fall, right? Or they have a lot more comorbidities. So you have to be careful with these, but quetiapine and clozapine are the least D2 antagonists, so it's really safe to give them to elderly. They're also very safe for patients that have Parkinson's, Lewy body disease, because they have less impact on the nigrostriatal dopamine depletion, so they will not impact their bradykinesia as much. That makes sense. So patients that have Parkinson's, right, they have that bradykinesia, this really, really slow movement. So that's why it's really safe to give something like quetiapine and clozapine, because it doesn't deplete their dopamine receptors as much as your first generation antipsychotics. And then we have Lorazepam or Latuda. This is used for bipolar depression. And another thing that you want to know is that risperidone, Trazadone, olanzapine have the highest D2 antagonism. So a question that I got asked is which one of these drugs of second generation acts the most typical? So basically, which one of these second generation drugs has more side effects or the higher tendency of having extrapyramidal side effects? Because it acts like a first generation drug, but it's a second generation drug. And the drug that does this is risperidone. So make sure that you know that risperidone is the most typical of the atypicals. So if you have a question and the patient's having extrapyramidal side effects and you're reading it and you're like, boom, I know what it is, it's a first generation drug. And then you read and you get down and you're like, okay, well, the first generation antipsychotic is not on there, but you see risperidone, then you can choose risperidone because it has the highest extrapyramidal side effects. Now that I'm going through this, I'm like, oh, I remember this question. And now we're going to go into risperidone. So risperidone, like I said, it has really high extrapyramidal side effects. And Trazadone is weight neutral, so you have to eat that with food. Okay, so Trazadone, weight neutral. And olanzapine, this is another one you have to know, has a worse metabolic offender, but it is the most efficacious of antipsychotics. So O, I memorized for weight gain. So olanzapine, weight gain. So you want to make sure that you are careful with this drug. So if a patient comes in and they're complaining that they've gained a lot of weight and olanzapine's on there, then it's going to be olanzapine. It's the worst metabolic offender. So you can memorize it, metabolic O, olanzapine O. That's how I think I memorized it. I just knew it was olanzapine, weight gain. And then you have your third generation antipsychotics. You have aripiprazole, Abilify. This is a really, really safe drug. My doctor prescribed this a lot, almost like every patient. And it comes in several forms. You can take it orally. You can even take it as a shot. My doctor prescribed it a lot as a shot. So basically the patient will usually be started on the medication orally. And then once the patient is going to be discharged, my doctor would prescribe a shot. Basically they give them a shot of Abilify, and that lasts for the entire month. So instead of you having to take Abilify every day, you just take the shot and it lasts the entire month. And I would have to explain this to every patient is they would ask, well, what's the difference in me taking the pill and taking it as a shot? Well, as a shot, it's slow releasing, so it releases through your body slowly, and this is how it's able to last for the entire month, which was really interesting. So this is Abilify. It's a very safe drug. It's great. A lot of patients love it. My doctor used it for depression. He used it for everything. It's a great drug. So some of the side effects of Abilify is, or aripiprazole, how you'll see it, is orthostatic hypotension, insomnia, tremor, headache, agitation, and anxiety. So what's the mode of action of this medication, which you'll get asked this for sure. It's a dopamine 2 partial agonist and a 5-HT1A agonism and a 5-HT2A antagonism. So make sure that you know that it's a dopamine 2 partial agonist. This is what usually sets Abilify in comparison to the other medications. And it's a very, very safe drug. Okay guys, so let's go into the mood stabilizers now. So we start with lithium. So lithium is the first line treatment for bipolar, okay? So bipolar disease, lithium. But lithium has a lot of side effects. So you have to make sure that who you're prescribing it with is a healthy individual and that they're not pregnant. Because if they're pregnant, they can cause side effects like Epstein's abnormality. So let's get into it. So lithium also decreases suicidal ideation like clozapine. Okay, so clozapine, like we had discussed earlier, it decreases suicidal ideation, and so does lithium. Actually, I had a question that asked which one of these medications will decrease suicidal ideation, and it was lithium, specifically in patients that are bipolar. So this medication, lithium, is a category D. It causes fetal malformation, like I said, Epstein's abnormality of tricuspid valve, and you also get your floppy baby syndrome. So you cannot prescribe lithium in women that are pregnant. Some of the side effects are weakness, tremors, increased weight. This is a huge side effect that a lot of patients did not like that were on lithium, is that they gained a lot of weight on it. Polyuria, decreased concentration. They can also cause hypothyroid. Okay, it decreases their T4. But this is reversible once they stop taking the medication. So make sure that you know that hypothyroid is connected with lithium as a side effect. It also has renal side effects. It can cause chronic kidney disease, also QT prolongation, bradycardia. So make sure that you know it can cause renal effects. That's another question I kept getting asked. You also want to watch out for dehydration and sweating, or if the patient's also on a thiazide or diuretic. It's very good. It works very well for mania, but it's not used, of course, for depression. So this is why this is usually used for bipolar, specifically bipolar 1. So you want to monitor levels with dose changes every 5 days. The therapeutic index is 0.6 to 1.2 millimoles per liter, so make sure that you know this, okay? The therapeutic index is 0.6 to 1.2. Basically, you want to make sure that they're in between this because this medication has so many side effects. And my doctor, we would do labs a lot on patients that were on lithium, and specifically if they were on high doses of lithium. And we always monitor that they were within that 0.6 to 1.2. So like I said, you want to watch out for renal effects. You want to measure their BUN and creatinine, pregnancy test, white blood cell count, their TSH, right, because it can cause hypothyroidism, their EKGs. You want to monitor their lithium levels, their BUN and creatinine, and toxicity, right? It can cause ataxia, coarse tremor, drowsiness, altered mental status, hyperreflexia, convulsion, T-wave inversion, and coma. So usually in the question stems, if you have a patient that is just really ill and they're having all these symptoms like renal side effects, problems with their heart, then you want to know it's lithium. Lithium is usually, I would put that a lot for a lot of the question stems with the patient that had really bad side effects because lithium has so many side effects. Like I said, you want to make sure the therapeutic index 0.6 to 1.2. I had some questions on that, so make sure that you know that. Okay, so now we're going to go into valproic acid, divalproic sodium, Depakote. Toxicity of valproic acid is altered mental status. You get your asterixis, seizures, coma. And this medication is also a category D, like lithium. It can cause neural tube defects. This is huge for valproic acid. So you'll get a question sim with a woman that's pregnant and they were on this medication. So it's either going to be lithium, right, or valproic acid. But if it's a neural tube defect, then it can be valproic acid. Side effects, it can cause transaminitis. So this is why you have to monitor their LFTs, sedation, weight gain, hyperammonia, so it can cause encephalopathy, pancreatitis. This one's also used for bipolar, helpful for bipolar depression, for mixed bipolar also. But once again, you also want to monitor the levels. So this is another one you want to monitor levels between 50 to 125 or 60 to 120 micrograms per liter. So make sure that you know that, and you also want to monitor their LFT and CBCs. And then we have our anticonvulsant stabilizers, mood stabilizers. So you have your carbamazepine, also known as Trazadone. This is category C. Side effects include ataxia, sedation, rash, amenorrhea, weight gain. You want to monitor levels also, LFTs. And also, let's go into lamotrigine, so Lamictal. Category C also, side effects, headache, sedation, vertigo, rash. Big one for this one is Stevens-Johnson syndrome. So if you have a patient that is having Stevens-Johnson syndrome, it's usually due to some type of anticonvulsant or even antipsychotic. And lamotrigine is known very well for causing Stevens-Johnson syndrome. So you have to also be careful with these medications. So both carbamazepine and Lamictal have Stevens-Johnson syndrome risk. So like I said, these anticonvulsants, they have a lot of side effects. So make sure that you know lamotrigine, carbamazepine, they cause Stevens-Johnson syndrome. Okay? And it's a really bad skin rash. Basically, your skin is peeling away and it can turn very deadly. So Stevens-Johnson syndrome, carbamazepine, and lamotrigine, that's something you have to know. And lamotrigine, it's used to treat bipolar depression. Next one's going to be topiramate, also known as Topomex. This one's category D. And side effects is that it decreases weight, sedation, memory impairment. That's why it's also known as Dopomex. Metabolic acidosis, paresthesias, hyponatremia, nephrolithiasis. And it's used as an adjunct, and it's good for substance use disorder, like patients that have chronic users of meth, coke, alcohol, tobacco, etc. Now we have gabapentin. So gabapentin, I feel like every patient is on gabapentin, whether it's because they're pain or they have fibromyalgia or etc. They just had hip surgery. So gabapentin, side effects include sedation or tremor. Like I said, it's usually used for pain, neuropathic pain also. Patients that also have diabetes and they have diabetic neuropathic pain, you can use gabapentin. And it's also used as an adjunct for anxiety. Although honestly, I didn't see this in questions and my doctor didn't use it in clinic, to be honest with you. I saw it more for pain, like neuropathic pain, but it can also be used for alcohol, opiate, sobriety, or withdrawal. But just know gabapentin, pain. That's it. Next one is going to be oxcarbazepine, Trileptal. I have a lot of questions on this. I did see it in clinic a lot though. Side effects, sedation, ataxia, hypothyroidism, used for pain also or fibromyalgia. Pregabalin, this one's another pain medication. Side effect, once again, is sedation, similar to gabapentin also, and oxcarbazepine. So pregabalin, sedation is used for fibromyalgia, pain, generalized anxiety disorder, and neuropathy. So these are pain medications, gabapentin, pregabalin, usually for pain. Okay, guys. So now we were going to go into beta blockers. Since we had discussed earlier is that you can use some beta blockers for some of your anxiety disorder, specific ones like social anxiety disorder. So the most commonly ones you'll see is something like propranolol or metoprolol. And side effects, since they are a beta blocker, they can cause hypertension, bradycardia, nausea, congestive heart failure. So I have a lot of tachycardias. My heart is usually higher than 100, and then whenever I work out, it will go higher than 150. So my doctors prescribed me beta blockers, and they cause really bad side effects. I actually sometimes would stop taking them because they would make me really, really dizzy and hypotensive. There would be points where I would just start sweating a lot and just feeling really nauseated. So just make sure beta blockers, hypotension, bradycardia, nausea, congestive heart failure. These medications, like I discussed, it can be used for anxiety or even akathisia. So akathisia is usually a side effect of your antipsychotics. And buspirone. So buspirone, it can be used for a lot of things. You can also use buspirone for a generalized anxiety disorder. Some of the side effects is dizziness, headache, minimal sedation. It's a very, very safe drug. And it doesn't have any addictive potential, but it takes a long time to go into effect. So it takes about 2 to 4 weeks for this drug to work, to kick in. I know my mom was prescribed buspirone, and I was like, Mom, that's actually a very, very safe drug, so make sure that you take it. It's really, really safe. And next one's going to be benzodiazepines. So benzos are used a lot, whether you're using it for your alcohol use disorder, benzodiazepine use disorder, or even for your anxiety. You'll see that a lot in clinic and also on your exams. So let's go into benzodiazepines. We have your high potency, your medium potency, and your low potency. So your high potency, you have alprazolam, also known as Xanax, and you have clonazepam, also known as Klonopin. Clonazepam, I feel like I see it everywhere in the movies, everywhere. Lorazepam, also known as Ativan. So what you have to know is that these are category D. So they have a lot of side effects like congenital abnormalities, CNS suppression, flaccidity, and side effects include sedation, impaired cognition, anterograde amnesia, altered mental status, especially in elderly. So you want to make sure that you're not giving these medications to patients that are older. So once again, you do not want to use these in elderly agitated because it can cause them to have delirium. And you also want to watch out for addictive potential. My doctor for psychiatry was an addictive specialist, so he specialized in addiction. We got a lot of patients that were on benzodiazepines and they were addicted, and they were new patients coming to my doctor that had been prescribed benzodiazepines in the past, and they were just addicted. They felt like they couldn't function without the benzodiazepine, or their anxiety would only be treated with benzodiazepines, and it's really, really sad. My doctor would argue with them all the time or try to wean them off the benzodiazepine because sometimes they were on such a high dose. And the one that I saw being prescribed all the time was clonazepam. For some reason, that one's really, really liked. But yes, they have a very, very high abuse potential and addiction potential also. For Xanax, alprazolam, also known as, you want to watch out for diversion. So these tend to be sold in the streets. So you want to be careful, right, when you're having those patients that are coming in constantly for refills, or that they're asking that they already ran out of their medications, or when you gave them a month's supply. You want to make sure that you're looking for these red flags. And you need to taper patients off of benzos, or else they can have withdrawal. And like I said, that's what my doctor would do. If a patient was on a high dose of a benzodiazepine and they wanted to get off the benzodiazepine and start a new medication, he needed to taper them off slowly. So usually he would taper them off like 5 milligrams off, depending on what dose they were, and just taper them off slowly. He would follow up with them whether it was bi-weekly or monthly. So you want to make sure that you're tapering them off and not just like completely shutting them off of the benzodiazepine, because they have very high addictive potentials. Another thing that you want to know is that clonazepam and diazepam, so diazepam is a medium potency, okay, is that they are long-acting. So the other ones like alprazolam and lorazepam, they are intermediate-acting benzodiazepines. So the longer the half-life, the decreased abuse potential for the benzodiazepine. So once again, the longer the half-life, the decreased abuse potential. So Ativan and Xanax have a higher potential to being abused because they have an intermediate half-life. So the effect wears off and they want to be taking it more and more. So Ativan and Xanax have a higher abuse potential because they are highly potent and their half-life is shorter in comparison to the rest of them. So let's look at the half-life. So Ativan half-life is 10 to 20 hours. And then we have Xanax half-life is 12 to 15 hours in comparison to something like clonazepam, which is 20 to 80 hours. So their half-life is a lot longer than these drugs. This is why these drugs have a higher potential of being abused. So medium potency, diazepam, Valium. And then we have your low potency drugs like chlordiazepoxide, also known as Librium. That's what I know it, and maybe because it's so hard to pronounce. So Librium is used for anxiety. You can also use it for alcohol withdrawal. And then you have your temazepam or Restoril. My doctor uses this a lot for insomnia, and that's what it's usually used for. And this drug is category X. So make sure that you know that from the low potency, temazepam is category X, and you can use it for insomnia. Okay, so let's go into hypnotics. We have hydroxyzine. Side effects for this medication is sedation, daytime somnolence, incoordination, dry mouth, urinary retention. So it antagonizes histamine. This is why you have all these symptoms of dry mouth, urinary retention. And this is usually used for anxiety. Hydroxyzine, my doctor prescribed this a lot. So now we're going to go into drugs that help you for sleeping. You have of course, your melatonin, which is usually what you can prescribe. It's something that's natural and it doesn't have as many side effects as the other medications. And then you have diphenhydramine or Benadryl, okay, for sleeping also. You also have your Ezopiclone, also known as Lunesta, so it's Ezopiclone. You can also use quetiapine for sleeping, like we discussed earlier, also known as Seroquel. I memorized it as S for sleep, Seroquel, quetiapine, sleeping. Trazadone, remember we discussed that also earlier, but patients don't like to take Trazadone because it causes what? Priapism. You also have your Zaleplon, also known as Sonata. And then you have your Zolpidem or Ambien that is also used to treat insomnia. So usually I have a question, it'll ask your patient, it'll tell you the patient is having trouble sleeping, so you can give them one of these medications, whether it's diphenhydramine, Ezopiclone, Zaleplon, or Zolpidem, which is a medication for sleeping. Okay, so now we're going to go into your psychostimulants, right? So these are used usually for ADHD. So your stimulants are going to be your first line treatment for ADHD, and then your non-stimulants tend to be your second treatment line for ADHD. If you have a patient, or sometimes we'll have in clinic mothers that do not want their children to be on stimulants because they've heard that they have a lot of side effects, although honestly stimulants are very safe, but mothers are usually still very concerned about the drug, then you can give them a non-stimulant like atomoxetine, which is one of the big ones that I kept seeing be prescribed by my doctor. Or if the patient has a high potential for abusing the drug, like say that they have a history of alcohol use disorder or substance use disorder, then you can do something like a non-stimulant like atomoxetine, also known as Strattera. So let's start with the psychostimulants, okay, so stimulant medications. You have your dextroamphetamine, also known as dextrine. You have your dextroamphetamine plus amphetamine, also known as Adderall. And you also have your less dexamphetamine or Vyvanse, also known as Vyvanse. Some of the side effects that these medications can cause is nervousness, anxiety, insomnia, tachycardia, hypertension, anorexia, especially methylphenidate. It can cause growth delay, weight loss, abdominal pain. So this is why with these stimulants, you want to make sure that you are watching for their weight. And that's what my doctor would do. He would take their weights every day, every time that he saw them in clinic. And what is the mode of action of these stimulants? So they are inhibitors for reuptake of dopamine, norepinephrine, and 5-HT. And for stimulants, we also have a methylphenidate / Ritalin plus Concerta. I saw methylphenidate a lot on my questions, so just make sure that you know it's stimulant first line for ADHD. And mode of action for methylphenidate is that it inhibits reuptake presynaptic dopamine, norepinephrine. And Concerta is also a long-acting form, and this one has less abuse potential. You also have dexmethylphenidate, also known as Focalin. So these are the stimulants, like I said, first line for ADHD. So let's go into non-stimulants. The most common one that you'll probably see is atomoxetine or Strattera. This one specifically is a selective norepinephrine reuptake inhibitor. Side effects are abdominal pain. You also have clonidine. This is an alpha-2 agonist. So side effects, of course, anything that's alpha-2 agonist, we're going to see dizziness, bradycardia, hypotension, sedation, and clonidine can also help with antisocial aggression, anxiety, opiate withdrawal. We also have guanfacine, and this one is a very selective alpha-2 agonist in the prefrontal cortex, and it's also a non-stimulant that can be used for ADHD. So now we're going to go into substance use disorder treatment, okay? So alcohol use disorder treatment. We can use things like disulfiram, also known as anti-abuse. Category for these are C. And side effects are nausea, vomiting, hypertension if alcohol is consumed, drowsiness, lethargy. So basically with disulfiram, what it does is that it accumulates acetaldehyde in the blood to produce adverse symptoms. So we also have a camprosal, also known as Camprol. This is used for alcohol use disorder also. It causes nausea, flatulence, diarrhea. It's an NMDA receptor modulator, so it decreases and reduces neuronal excitation during withdrawal. And it's renally metabolized, so it's good for patients that have liver problems, okay? But it's bad for patients that have kidney problems. So if you have a patient that has cirrhosis because they've been drinking so much, then of course you wouldn't consider something like a camprosate. So you also have naltrexone. Side effects of naltrexone are nausea, vomiting, dysphoria. And then you have gabapentin or Neurontin. Side effects are sedation, ataxia, vertigo. And then you have something like topiramate. This one's actually class D. Okay, topiramate, it can cause cleft palate. Okay, so let's go into our opiate use disorders treatment. So we have buprenorphine plus naloxone, also known as Suboxone. And we also have just buprenorphine by itself. Side effects is that buprenorphine, it causes QTc prolongation, it causes increased intracranial pressure, respiratory depression, and nausea. It's a partial mu opioid receptor agonist, okay, and a K opioid receptor antagonist. So make sure that you know that for buprenorphine. I had a question on that. Mode of action is partial mu opioid receptor agonist and K opioid receptor antagonist. And for naloxone, this one is a mu receptor blocker. So that's why Suboxone is very helpful, because it provides both a partial agonist, and this helps in preventing cravings, withdrawal, while also having your naloxone to block the mu opioid receptor to prevent euphoria. So they work synergistically together. So then we have naloxone, also known as Narcan, right? I know in certain cities, usually taxi drivers will drive around with Narcan, specifically areas that have a lot of opiate use disorder. That way they can just have it in their glove box compartment and use it when they need to. So some of the side effects of naloxone are ventricular arrhythmias, hypertension. These are really good for ER, like I said, in an emergency situation. You want to give it to your opiate patients, and this can actually save their lives. And then you have methadone. This one, side effects are QTc prolongation, drowsiness, insomnia, nausea. It's a synthetic opiate that acts on mu opioid receptor, and it prevents opioid from causing euphoria. And then you have clonidine. Okay, this one reduces autonomic hyperactivity of alcohol or opiate or tobacco withdrawal. Now for tobacco use disorder, we can use bupropion, like I had discussed earlier in the antidepressants. What was the mode of action for bupropion? It blocks dopamine, norepinephrine, it inhibits nicotinic brain receptors, but you want to make sure that you start this 1 to 2 weeks before they start to quit. So this is really important. Bupropion, you want to make sure that you start it 1 to 2 weeks before they start to quit. You can also use nicotine replacement therapy like gum, lozenges, patches, sprays. And you can also use something like varenicline or Chantix, but side effects are nausea, headache, abnormal dreams, insomnia. And mode of action is that they block nicotine at the nicotinic receptors, and they also release dopamine. So now we're done with all the medications. Now what I want to go into is the different type of psychotherapies. Okay, how to differentiate between family therapy, cognitive behavioral therapy, motivational interviewing, etc. It's something that you'll see a lot in your questions. I definitely did not see any of this in clinic. I saw more of medication management, but it depends whether you're with a therapist or not. So let's get into this. Most of these you'll see them in questions, so it's going to be really important you know these for your EOR. So behavior therapy. We have different types. We have your aversion therapy, your biofeedback, your flooding, and your systematic desensitization. So what is a main, what are you going to use behavioral therapy for? So you're going to use it to eliminate maladaptive behaviors, and you want to replace them with healthy behaviors. So aversion therapy, what is it? You basically give a patient a negative stimuli, something usually that is harmful, and whenever a harmful behavior is completed. So for example, is anti-abuse, right? So anti-abuse, like we had just talked about earlier, which is used for alcohol use disorder, it's also known as disulfiram. This could be an example of aversion therapy. Basically, the patient's taking the medication, they're on disulfiram, and whenever they drink alcohol, it makes them very sick. So they learn not to drink alcohol when they're taking that medication because it makes them really, really, really sick. But the thing about this medication, which I apologize, I forgot to discuss, is that with disulfiram, sometimes the patient can just learn to stop taking the medication and they can still drink. So the patient has to make sure that they're taking the medication for them to be able to have those side effects of when they drink alcohol. So this can be an example of aversion therapy. So what is it used for? Substance use disorder or even anxiety. And then you have your biofeedback. Biofeedback, basically, it gives patient measures of their physiological state and have patients try to control voluntarily their vital signs after being presented with a stressor. So examples of this is chronic pain, anxiety disorder, migraines, flooding. This one's actually really, really scary. Basically, you expose a patient to a noxious stimuli. So this is usually used in phobias. And you bombard them over and over again until the patient discovers how to relax themselves and calm themselves in the face of the stimuli. So, for example, someone that's scared of spiders, you can put them in an area where there's spiders and just bombard them with spiders until they know how to calm themselves and relax themselves. I don't think I could do that because my phobia is enclosed spaces. And then you have your systematic desensitization. This is also part of your behavioral therapy. You have patients try to relax on their own and gradually introduce an anxiety-provoking stimuli. This is also used for phobias and also anxiety. So let's go into cognitive therapy. Cognitive therapy, what is it? You want to correct negative thoughts, okay, in response to stressors and change them into something productive or beneficial. This is usually used in personality disorders. So we had discussed personality disorders earlier, something like borderline personality disorder, schizoid, schizotypal. Now we're going to go into cognitive behavioral therapy. This one for sure you have to know. I saw this on every single question that had to do something with a psychotherapy. So make sure that you know. If I didn't know the answer, I would just usually put cognitive behavioral therapy. It's very, very, very common. So you have general cognitive behavioral therapy and you also have dialectical behavioral therapy. So with general cognitive behavioral therapy, you want to focus on the patient, on how they're feeling, their behaviors, and how they are influenced by their thoughts. So in here we combine behavioral therapy and cognitive therapy by opening a patient's eyes up to their own distorted thinking patterns. You allow the patient to set up an agenda, you give them homework and that they must complete, you review their homework, and you challenge their thinking patterns. So what is this used for? This is used for major depression, PTSD, generalized anxiety disorder, panic disorder, OCD, substance use disorder, and a lot of other things like separation anxiety, body dysmorphic disorder. But the ones you need to know, major depression, PTSD, anxiety disorder, panic disorder, OCD, and substance use disorder. And then we have dialectical behavioral therapy. Okay, this one is very unique to certain disorders, so make sure that you watch my previous video. For example, it's very unique to borderline personality disorder. So if you have a question and it asks you what psychotherapy will be beneficial in this patient, do not choose general, choose dialectical behavioral therapy. So what is it? It's a form of cognitive behavioral therapy with weekly individual and group therapy sessions. And like I said, it's used for borderline personality disorder. And then you have family therapy. This is where you get the family involved. You talk about tensions that are probably occurring in the family. You try to reduce conflicts. You allow the family to be empathetic with the patient. Indications are anorexia, bulimia, ADHD, autism spectrum disorders, ODD, major depressive disorder. And then you have insight-oriented psychotherapy. Therapy over 4 to 5 days per week. This allows the patient to freely express their emotions to uncover their unconscious thoughts and attitudes. Usually used for phobias, panic disorders, OCD, sexual inhibitions. And then we have motivational interviewing. You try to motivate patients to pursue and change their behavior. This is usually used for substance use disorders. And finally, the last one's going to be supportive psychotherapy. You try to be the patient's friend, you build up their ego, usually through mutually productive discussion, discuss solutions to issues brought up by the patient. This is used for major depressive disorder, adjustment disorders. And yeah. Alright guys, so that was it. I am done with all the medications and also the types of cognitive behavioral therapy or just general therapy in general. I hope that this video was helpful for you guys. If I have any mistakes, make sure you comment below. Or if you also have any cool ways of remembering certain medications or mnemonics that you learned, make sure that you comment below. You can definitely help out other students. So I hope you guys liked this video. As always, please give it a thumbs up. If you have any comments, make sure you comment below. And also any feedback that you can give me so I can make better videos for you guys in the future. Alright guys, I'll talk to you guys later. Bye.